So today we're here to talk about the cost of delayed diagnosis in rare disease, and I'm excited to be joined by Dr. Kim Stevens with Project Alive. Let's see. So if you saw our caucus briefing last week, this may all look a little bit familiar to you, but I'm gonna kind of start from the beginning here. So in 2020, we looked at 379 rare diseases in our National Economic Burden of Rare Diseases study, obviously economic burden being an economic term. And through that study, we estimated that the costs of living with a rare disease in 1 year of 2019 was $1 trillion in that 1 year, just below 1 trillion, and that 60% of the overall costs were indirect and non-medical costs. So those were costs absorbed by the families. And the most significant cost driver of the other 40% were inpatient costs and outpatient care. So the first study on the economic impact of rare diseases and the lived experiences of rare disease patients and families was just skimming the surface, we learned, and we really wanted to see what else there was to learn. So we started to think about the diagnostic odyssey. And in the first study, in order to participate, you had to have a confirmed diagnosis and an ICD code for your rare disease. And as we know, the diagnostic odyssey is not a straight line. It is often very twisty and curvy. It sometimes looks like chutes and ladders. Other times it's never ending. And by the time someone receives a diagnosis, they've already gone through these twists and turns with hospitalizations, specialists, tests, and disease progression. So in our first study in 2019, we had a survey that just about 1,300 people filled out. And we asked some questions beyond the costs that included the medical burden of a long diagnostic odyssey. And from the study, we learned a number of things. We learned that the average length of the diagnostic odyssey from the first symptom is 16 and a half years. We learned that patients navigated without a rare disease diagnosis for an average of 6.3 years, and we learned that an average of 16.9 specialists were seen by a patient. And then, of course, we found from the survey that patients also had a myriad of other experiences, saw a number of other healthcare providers, had a number of other healthcare events before receiving a formal rare disease diagnosis. They saw multiple physicians and specialists, emergency room visits, hospital admissions, and traveled out of state to receive care. So from the first study on the economic impact of rare diseases, we wanted to dig deeper. We wanted to learn more about the diagnostic odyssey in order to better understand the cost of the delayed diagnosis in rare diseases. So we started with what we already knew about the diagnostic odyssey. We started with the diagnostic odyssey results in delayed or missed diagnoses. Delays in accurate diagnosis can yield inappropriate clinical management, unnecessary medical interventions, and missed treatment windows for therapeutics interventions to optimize health outcomes or prevent disease symptoms onset. And that it also contributes to increased probability of irreversible disease progression and complications, ultimately putting patients at risk for preventable mortality and disability. We also know that we have the technology to do better, right? We have advancements in technologies to screen, diagnose, treat, and manage rare diseases that potentially could dramatically shorten and even eliminate the diagnostic odyssey. So the goals of the study on the diagnostic odyssey were threefold. The first was to provide an estimate of potential cost savings that may result from shortening or eliminating the diagnostic odyssey. Specifically, we aimed to understand the patient journey prior to diagnosis and then quantify the medical costs and productivity losses of a delayed diagnosis. And we ventured to peek under the surface and examine more of the iceberg. For the study, we analyzed data sets from Medicare and Medicaid and private insurers from the years 2016 to 2020, and the patients were placed in two different cohorts. So patients were placed either in the timely diagnosis or the delayed diagnosis cohort. So the timely diagnosis cohort was made up of those that received a first diagnosis before the age of 1 year. And then in the second category, the second cohort, was those that received a first diagnosis on or after their first birthday and before age 12. And we chose 7 rare diseases to use as case studies in order to develop this methodology that could be used for other rare diseases in the future. So the first 7 included SCID, Pompe, ALD, Fragile X, Duchenne, MG, and Wilson's disease. And the analysis was informed by detailed patient journey maps based on literature reviews and consultation with disease-specific experts to guide the study. We also had 27 experts that served on a panel that informed the research, clinical, and patient advocacy communities. And also, we developed a whole new productivity loss methodology. So we used a different methodology for productivity loss than what was used in our first economic burden study. And so for the productivity loss, we used a new methodology. For instance, we used a method that would estimate the work hours based on the work hours missed based on the medical appointments. So a physician office visit equaled 0.25 missed days of work. And this method likely underestimates productivity loss for patients and families with rare diseases because it doesn't account for travel, time spent on finances, which we all know is a drag, or coordinating care, which is also very time consuming. For the 5 pediatric onset rare diseases, you can see the difference between a timely diagnosis in the first year versus a delayed diagnosis after the first year in the total costs of medical costs and productivity loss. The shaded area is the age at diagnosis, and the bars are the cost. And you can see that on the left-hand side, the costs for ALD, Pompe, and SCID are 0 when the age of diagnosis is at 0. And then you can see the differences between Duchenne muscular dystrophy, which is the blue, between the early diagnosis in the middle there in blue of Duchenne muscular dystrophy versus the late delayed diagnosis at the end of the bar. And the same for Fragile X, which is labeled FXS, at 13,000 for an early diagnosis versus further on down the bar of a late diagnosis is much higher at 160,000. And then similarly, you can see that per patient for those 3 rare diseases with newborn screening, the difference between the cost per patient for ALD, Pompe, and SCID. And then this illustrates the number of costly out-of-state trips that were made during the diagnostic odyssey in relation to the length of the diagnostic odyssey, many of which was absorbed by the families. And the longer the diagnostic odyssey, the more trips out of state. And it might be a little bit hard to see, but the first 3 are in children and the second 3 are adults. So then we have the data broken out by disease. So looking directly at the impact of delayed diagnosis in Duchenne muscular dystrophy, the delayed diagnosis dramatically increases costs for families. So $211,229 total medical costs and productivity loss per family, 20 lost days of work for caregivers each year, and 17 out-of-state trips for medical care across 7 communities that were studied. And then conversely, it's hard to see the difference between slides. This is Pompeii, and you can see that for Pompeii, the impact, again, the delayed diagnosis in Pompeii directly increased costs for families. So similarly, it was $219,081 total medical costs and productivity loss per family, 9+ lost days of work for caregivers per year, and 41 additional hospital visits, physician appointments, and other medical interventions. I think that number 41 really stands out to me. And so overall, our in-depth look at the diagnostic odyssey across the 7 rare diseases found that the economic impact of medical costs and lost income for individuals and families totaled between $86,000 and $517,000 per person, an average of $220,000 across the diagnostic odyssey. And these are, of course, avoidable costs. This study shows the positive economic impact of our newborn screening program and newborn screening and early diagnosis in general, especially for diseases in which early intervention is key. The cost of the diagnostic odyssey can be eliminated for diseases like SCID, ALD, Pompeii, where newborn screening is routine in many states. And as I saw a rare disease community member say, that not included in any of these numbers or figures is the mental anguish and distress of the uncertainty that these individuals and families live through this process. Of course, there are always limitations to every study. So there were challenges of ICD codes and variable subtypes. The majority of rare diseases have significantly longer diagnostic odysseys, and these findings are extremely conservative. And then, of course, the productivity loss methodology is also extremely conservative as well. And so I just want to finish by acknowledging first, of course, this study was spearheaded by the EveryLife Foundation, but Annie Kennedy, our Chief of Policy Advocacy and Patient Engagement in particular, and a large group of people within the community from those 7 rare diseases, as well as advisors from NIH, industry, the Lewin Group, our partners at Smith Solve. This was definitely a very heavy lift that was taken on by many, many people within the community. So thank you, everyone, for being here today. We do have materials at our table as well on this study in particular. So if you have any questions or want more information, please don't hesitate to reach out to anyone on our team. But I would love, at this point, to turn it over to Dr. Kim Stevens with Project Alive and the Joseph Muenzer's MPS Research and Treatment Center of UNC to discuss more from the personal side of what a delayed diagnosis means to rare disease patients and families.
Thank you, Shannon. So that was great. Thank you for sharing that. And I do want to stress how important knowing that economic impact really is, especially when we're going up to Capitol Hill and we're trying to quantify what does a rare disease impact to the family. And I'm up here to talk more about the personal part, but mostly because every time EveryLife asks me to do anything, I say yes. So I want to start with a video. And they're going to cue it up, and that was the delay earlier, so I apologize. You'll excuse my tears. I don't get to hear my son's voice anymore. That was Cole when he was about 3. He loved to sing medleys in the car. As you saw, his sort of own mashup of songs. But for me, the delayed diagnosis means I can't hear my son's voice anymore. He stopped speaking about 9. And Cole has Hunter syndrome, or MPS II. So he's missing an enzyme that takes waste out of his body. So it gradually builds up in all the organs and eventually will lose his ability to walk. He's already lost his ability to talk, breathe on his own, and most of our boys pass away in the second decade of life. I often talk about this and say, you know, in my mind, Cole, he's 13. The average age is 15. So I come with a lot of urgency, knowing that, do I have 2 years? Not sure. Do I have 3 years? I don't know. And I have to go back and say, what would that diagnosis have meant? I do a lot of newborn screening talks now, and I have to take a step back and say, what would have happened if Cole had been picked up by newborn screening? He was diagnosed at 2.5, late for a child with MPS II. He was already starting to lose skills at that point. I didn't know that. There was a delayed speech, but the doctor, his pediatrician, had said, oh, you know, boys start talking a little bit later. He had double hernia repair. The pediatrician said, you know, a lot of boys have that problem. He had constant ear infections. Well, he's in daycare, and his brother is as well. So all kids have ear infections. It wasn't until we moved from Austin, Texas to Tennessee, and we started with a new ENT that had seen Hunter syndrome before. And he said to me, after he had done Cole's adenoids shaving down and new ear tubes, I think your son has a rare disease. I think he has mucopolysaccharidosis. Never heard of it, never even thought about it, hadn't even considered that Cole had a rare disease. But now, my life was forever changed. And that's part of the impact of a rare disease, right? And for many of us that experience that diagnosis or are told that day, we remember that day. Always remember that day. My life changed that day. Our family's life changed that day. And I remember coming home, and the doctor had said, your son either has MPS I or MPS II. And I was so angry, so very, very angry. And I went for a run, and I can remember it just like it was yesterday, and it wasn't. And I went for a run, and I thought, I can do this. I can outrun this disease. And I just started running as fast as I could. I'm not a fast runner, but I was pretty fast that day. And then I fell to the ground and cried. And then, like all of us, probably that are here, we picked ourselves up and said, what am I going to do next? And so I found the best doctor, probably in the world, Dr. Muenzer, who is now my boss, and said, I'm going to go get the best care that I can for my son. And that's when I got into advocacy. And Cole joined a clinical trial, but again, 2.5 is late. And he didn't get into the clinical trial for 2 years after diagnosis because the FDA had put a hold on the clinical trial. So we were waiting. I was watching Cole. I said, is he losing a skill? Is he slower than the other kids? Comparing him and thinking, I just got to keep my boy alive long enough for him to get in this clinical trial, and then it'll be okay. If we can have the slide up next. Do I need to do that? I don't know. Anyway, we'll wait for just a second. So where is Cole today? Well, as I mentioned earlier, Cole just had his 13th birthday in July. He's a very happy kid. As I mentioned, he quit speaking about 9. It was a gradual. It's not just wake up one day and he's not speaking. His words got less and less. He went from about 200 words to about 100. And then you start thinking, oh, he's speaking in 2-word sentences. And now he's speaking in 1 words. And the last word he kept going back and forth with was mommy. And I remember going to a playground and he, mommy, 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 mommy. And I was like, oh my gosh, he keeps saying that. But I didn't care. That was his last word. I never knew when it was the last time. It just happened. I still think about that and that's all I want for him at this point, to be able to speak. He's doing well physically. We go on 3-mile hikes on the weekends. He can breathe on his own. He can feed himself. He can somewhat dress himself. Some days he has good toileting days. Other times I'm changing his pull-up for him. But he's alive, and that's the most I can ask for at this point, because I can't go back in time. And as my good friend Kristen said in a grieving session earlier, I have to keep myself focused and time right now, right? I can't get ahead of myself, and I can't go back. So I've got to stay right where I am. And I say that a lot. And you know, sometimes I wake up every morning thinking, is this going to be the day? And I'll go in his room and just sit there with him. Think, is he breathing? He's breathing. Okay, I can sleep. Because I don't know. And so that's the delayed diagnosis that you can have here. I'm also divorced. 17 years I was married. My husband never joined me in the journey. And I held on for a while, probably longer than I should have, because I needed insurance for Cole. Because I left my job of 20 years at IBM. I worked full-time the entire time because I was worried about insurance. But I went to work for a nonprofit and we didn't have insurance, so it's dependent, right? So where we are now, and what's interesting, Shannon, as you were sharing the economic impact, what's not captured is I had to pull back my career, right? And that's a very small thing. I wouldn't trade that for anything. I needed to spend that time with Cole. But I didn't travel as much. I didn't go to New York like I was doing for IBM. And my salary took a hit for it. I didn't get promotions because I was just trying to maintain. That's all I said. It's a job. It's okay. I don't really like it that much, but I've got insurance and it's a steady job and I know how to do it, right? So that's part of it too. Now I'm a single mom. I don't know what I think about that title. I never thought I would be a single mom. And my income is cut a lot. My former husband was an IBM executive. He doesn't see my son. He'll see the other son. That's typical. but he doesn't see his special needs son or Cole. He doesn't pay anything to help with Cole. So these are the things, the invisible things that can't show up, that we can't put in a survey. But it's still important for us to have those numbers, to know how much it costs for that. But we also have to think about the emotional impact that takes, what it takes on the family. My other son is 15, so he's at that age where no one knows anything, and it's embarrassing for me as a mom to even breathe. And he and his brother, my dream of them being best friends 2 years apart, that doesn't happen. Connor doesn't, who's my 15-year-old, he just tolerates Cole. So there's a lot of things that aren't shown there, and I assume this is why you asked me to speak. If not, then I'm, going off the rails here, but that's all right too. And one of the pictures that I didn't get to share that's really, really impactful, there's a family, and they have 3 kids with Hunter syndrome, MPS 2. 3. And I'm thinking, I'm trying to manage 1, and she has 3. And she's a single mom too. And so she had her first boy, King, is the middle child actually, and Hunter, which is an unfortunate naming, since that turned out to be his disease, Hunter is the oldest. And the younger child is NASH. And Hunter was diagnosed, and then they diagnosed King. And then because of that, when she was pregnant with NASH, he started treatment right away. And he entered the clinical trial that my son was in. Now, I had a picture, but you can imagine, if you put the 3 boys together, NASH, you wouldn't be able to tell he had Hunter syndrome. You wouldn't be able to tell anything. He started treatment as soon as he was born. Hunter has passed. King was also not eligible for the clinical trial. So he has profound cognitive impact. So imagine that you have your own sort of research study in your home, and that's what you're watching. And that's what my friend Brittany is doing, just waiting. She's a strong woman. But that is the cost. Watching your children lose skills, pass away. And that's why we need these sort of surveys to figure out, well, what's the economic impact? Because sometimes when you go up to the hill, that's what they want to hear, right? We can tell our patient stories, tug at the heartstrings, but when we walk away, they're wanting to know, what can they do? And what can they do? Well, they can surely fund some legislation. They can make sure they put in the language and bills that will help with our kids with rare disease. Newborn screening is amazing. MPS 2 got added to the RUSP this past year. And so now we're going to have kids that are going to be diagnosed. And what do we do with them, right? And as most of you know, with the RUSP, it's just a suggestion. I say, it's just right. It's a recommended uniform screening. It's not, many states have alignment, so automatically alignment, which basically says if it's on the federal RUSP, within 2 years, as a state, I'm going to implement it, right? But there's costs, there's lab costs, and there's many states that we're going state by state. And EveryLife has done a tremendous job of going state by state. And my friend Crystal in the front in Texas has been so instrumental in this area. And so what do we do here? We need voices. We need people sharing stories. And then when we get them sort of hooked with this story, we share this data and said, here's what we need. We need appropriations language here. Here's where we need some of that money. Here's how we get newborn screening. We have automatically alignment across. Why do we have to go state by state? It's very hard. I was a couple weeks ago, I was speaking at a lab with lab folks in New York talking about newborn screening. And the next day I flew to Austin because I needed to talk to the Texas folks. And I was worn out that week. I thought, I can't tell my story multiple times. It's draining. It's hard to go back there. And I said to myself, I've got to get more people talking about this. I need more me, or people that may be even better than me, to be speaking about this. I spoke to someone earlier at this conference who said that she wanted to speak about that moment of bliss that we might hear about between diagnosis and this not knowing. And I'm hearing this a lot from legislators talking about this moment of bliss. And we've even heard from the HDNC, and that's the folks that decide what goes on the RUSP. Should we really even tell parents? You heard that. Should we even really tell parents that their child has this disease, especially if there's no treatment? I say, and I get a little bit fired up about this, it's not your choice. The only person that can make a decision is the parent, the caregiver, the patient, about whether or not you give them the knowledge. You should not be holding the knowledge back from them, right? So this is where our voices come in, and we need to be speaking up and saying, you know what, we need more diseases on the RUSP, we need quicker implementation of that. And we also need to be making sure that we're thinking about those patients and caregivers when we're making these decisions. And sometimes they're decided on numbers, and sometimes they're decided on, sometimes I swear I'll be listening to them and I think it's on a whim, depending on what they had for lunch that day. But I know it's all following some process. But I know, and I joked when I first came up here and said, every time EveryLife asks me to talk, I do. But that's true. I've been back to speak to this group, AC and HDNC, 4 times, I think, in the past 2 years as co-chair for the newborn screening with EveryLife. And every time I come back to them and I'd say, hey, it's me again. What are you doing? Here's what I need you to do. I need you to move faster. Right? And that's what we can do too as rare disease parents, as advocates, anybody here, is we've got to convey urgency. You know, for some people that are making these decisions, Wednesday's just another Wednesday. We'll meet again about this next month. And we've got to bring a face to these diseases and say, we can't wait. This is not a quarterly disease. My child, by the time I come back to you, may have passed, but I'm going to keep coming. So that's my little soapbox for today. If you know me, you know I have many soapboxes. But also appreciative of what EveryLife works that they're doing, and the way that they are engaging patients and trying to figure out and quantify and use language that our legislators understand. So I'm going to turn it back to Shannon. Do we have questions, or what do we need?
Thank you, Kim. I think we have like 10 minutes left, so we can open it up to questions from the audience. If anyone has any questions for us on the study, on diagnosis, on newborn screening, on diagnostics, we can see about answering them.
If not, I'd love, Crystal, if you would talk a little bit about Texas. Put you on the spot.
Right.
There's a microphone right behind you.
So I'm fairly familiar with newborn screening in Texas. I'm on the Texas Newborn Screening Advisory Committee. I motioned to create the Rare Disease Subcommittee, and I chair that subcommittee. We have 400,000 births a year, roughly, in Texas. So we put a lot of blood spots through newborn screening in Texas. And for me, you know, when you see babies in the hospital and then they're in those isolates, for me, I don't envision the blood spots going through. I see those isolates with those babies in them moving into the newborn screening lab and then coming back out the other side. And we also screen those babies twice, so that's 800,000 screens a year, because Texas does not want to have any false negatives. So we want to make sure that if a baby has a condition that can be picked up, that we will do everything possible to pick those up. And really want to work still toward improving newborn screening in Texas. We're really close to RUSP alignment. We don't have a definitive timeline, but we do have reporting requirements that holds the newborn screening laboratory accountable now. And I know I was actually absent the last legislative session, but Leslie and EveryLife worked on that together. So thank you, thank you, thank you. And I know some of the other improvements that we're working on at Texas Rare Alliance is making Texas a pilot program state, because we are such a large state and we have so many births. It's a great way that we can complete pilot programs very quickly. And then we're also working on implementing screening prior to RUSP inclusion, which the advisory committee can vote to do. So I would say those are our two top initiatives right now for improving newborn screening further. And thank you so, so much for this quantitative data, because when we go in with our qualitative data, our storytelling, again, we can't just pull at the heartstrings anymore because they're savvy, and we have to pair that with the data. We have to become proficient at data storytelling. So this is just an amazing tool to help us accomplish that. So thank you very much.
Thanks, Crystal. And great job in Texas.
Shannon, can I ask you a question?
Sure.
It's unscripted. What's next? So this covered a lot, but what are we going to go next? Get more data and learn more?
That is a very good question. I am sure Annie's mind is churning and Ted's over there laughing. I think that's something our team is in the works of discussing, kind of the new direction. We actually had two big things come out last week, so it wasn't just our economic impact of delayed diagnosis, but we had our newborn screening modernization roundtables white paper came out last week. For those of you who have advocated with RDLA at Rare Disease Week, for instance, before, you might be familiar with the Newborn Screening Saves Lives Reauthorization Act, which went reauthorized. It is overdue. Luckily, the newborn screening program is able to continue on for the most part without the reauthorization by the magic of government, but really looking on what is next for the Newborn Screening Saves Lives Reauthorization Act, how we can modernize that system, what steps we need to take, knowing what technology is available to us now, the impact that newborn screening has, and how we can continue to improve that system. So I think that is definitely on the horizon.
Great. Do you have any more?
Well, question. Sure.
Can't see.
The lights are so bright.
So everyone online can hear what your amazing question is. I was trying to be loud, but Jennifer, ATRX Research Alliance, we represent ATRX syndrome. Very new to this space. Our organization is only 2 years old, so I just want to ask a very humble question. We know as a patient community that we are very underdiagnosed, and so I know that newborn screening is very important, and my question is, how would one get on the RUSP and start spreading ourselves to be on those lists amongst all the different states so we can try to find more patients and help get kids in therapy sooner?
That's a good question. Kim, do you want to talk a little bit about that process?
Well, I will talk to it from a sort of a patient advocacy perspective. It is a process. You create a package that will go to the committee, and you're submitting that. And part of that is looking at, where is the disease state? What is the current treatment? Is there a treatment? Because that's very important to the committee when they're voting. Is there a treatment right now? What is the cost of not diagnosing this, both to the impact or to long-term life expectancy or even quality of life? And so you'll put together that whole package, and then that will be submitted, and then they'll bring together a committee to review that and look at all the evidence. And part of that package is you're getting your experts to give their opinions, and you're citing those experts. You're also giving the patient perspective. So it really is a process of, I think for MPS 2, it was over 2 years to get that together. So I think it's at any point, patients can start, advocacy organizations can find out what information they need to pull that to, and that's on the web, is it?
On the HHS website?
HSS website that tells you what you want to include in there. But a lot of it is going out into the research and seeing what's out there, the published papers, those sort of things, and pulling that into your package. And then the review committee, they review everything, and then you have a person on that, speaking to that committee that sums it all up, and then they'll vote to review it, and then it goes forward another step, and at any point they can send it back to you and say, no, we need more information, or we need this sort of thing. So it's a process of doing that, but a lot of it does, in my opinion, depend on if there is a treatment for it. Why do we need to intervene? Is there something that can be done? Like, for instance, PKU. The sooner you get for PKU diagnosis, you can get the child on the diet that will help them not have symptoms of that. So that was easy. That's not an easy ask. I don't want to say it that, but that seems pretty. And for MPS 2, we do have treatments now. There's a standard of care of enzyme replacement therapy that's been around since 2016. So again, that was sort of putting that out there as well. Do you want to add anything else?
No. If you would like any more information, we have folks on staff who specialize in this area who can certainly give you more information and help guide you if needed and wanted.
And really do take advantage of EveryLife. We are in Project Alive and in my current role at the MPS Center, rely heavily on them. I often joke with them that I'm their unpaid volunteer because and the same thing, I'm getting something back from them, but I'm learning, and everything that I've learned to be an advocate on Capitol Hill and about newborn screening is because of EveryLife and just getting involved. And you can join a committee, you can go to the website, any of those sorts of things. So
Lots of ways to engage and get involved.
I think Rachel's
Yes,
given us the
I
hook.
think so. Thank you, everyone. Thank you.
Thank you so much to our presenters. Can we give them a big round of applause?